room should be well lighted, and we need to instruct our patient how to use the call bell, not just free call bell, but we will not teach them how to do. So we need to educate our patient, and it should be within the reach of our patient. And especially, we need to attend call bells. We need to assist our patient every time they need to ambulate, especially for post-operative patient. And most especially, we need to do our MORS call assessment and reassessment. Those things we saw are like basic for us, but we need to live with it every day to decrease the incidence of fall. Thank you. So next, we will be having a case presentation, which will be given by Ms. Ibon and Ms. Vidamon. Thank you.
Working on lagi? Linggo. Live on lo.
Thank you so much, friends. And good morning once again, everyone. I'm Yvonne Bayuyos from Train 8 in Neurocardio Ward. And now I'm going to present to you the incidence rate of fall in Counseling J for the last 2 months. For the month of April, we have 4 cases of falls and every week. That is the growth cases. Then for the month of May, it reduced to 3 cases. 1 in the first week, none in the second week, but on the third week there is 2 cases of fall, and none on the last week. So now we are going to present to you this case presentation for the incidence of fall that has happened in my area. This happened on April 28, 2021 at 6:45 in the evening. This is a case of stroke, a 48-year-old male patient. He was admitted due to right leg pain and with history of DM, hypertension, and psychiatric disorder. For the risk level for this patient, from the previous shift, he was assessed as high risk for fall. But during that shift, the incident happened, the patient was assessed by the nurse as low risk. So the incident happened when the patient tried to get out of the bed and fell with half of the body on the floor. Then the IMC was removed. Then the staff immediately assessed the patient and informed the doctor. Then the patient was transferred to the room near to the station. So far, no injury happened to the patient. Then the attending physician advised for the condom catheter thereafter. As per the investigation of the nursing quality, the patient was confused, a psychiatric case under the antidepressant medication. Then, during this case, the incident happened, the nursing quality was present. So, it was witnessed and the immediate environment was observed. All preventive measures were instituted. Siders were up, but the patient slid up the gap in the bed. Patient was halfway falling from the bed. So as I said, no injuries happened to the patient. For the contributing factors for this patient, this is related stroke and psychiatric disorder. Can I ask one of the audience, Ms. Anne? What do you think the contributing factors why the patient has having this incident of fall?
For me, I think one is the wrong assessment during Morse fall. It was like low risk assessment. And then another thing is her condition. He has history of stroke and psychiatric, also patient is psychiatric. And he has received medications, which increases the risk for fall. And patient has also retinopathy, which is the complication of his diabetes.
Thank you so much, Anne. So it was said by Anne for the contributing factors. Then for the corrective measures, since the nursing quality was present during that time, so the staff counseling was done and enforcement of all preventive measures also was done. As a staff nurse, I would like to recommend that every one of us working in the area should assess our patient properly in order to have we can have a plan that is intended for our patients that prevent the patient from fall. Then for this case also the patient was confused with the story of psychiatric disorder. We can ask the attending physician that we can refer to the social worker to have an accompanying. Then upon admission, if we can assist the patient that is high risk, especially like this one, we can ask our charge that we can put the patient nearest to the station so that there is a lot of nurses. We can ask from them to check the patient frequently. Then it's not 2 hours frequently checking the patient. Then we make sure also during the endorsement time to watch the call bell because or should check your patient because this time the call usually happen because every one of us is waiting for our incoming nurses and we are not attending to our patient. So this time we should be watchful. In the additional recommendation from our audience. I saw one of my colleagues from TA, Anne.
Loud, mic. Mic.
As you said already, if you take adequate precaution, we can prevent more, like proper assessment and those the patient is high risk, we should attend the call, cycle should be up, and we should provide a slipper to the patient who is able to walk. And I think if we follow all of these measures, we can avoid the patient family.
Thank you so much, Anne. Then for the next, Miss Vito.
Good morning to all. I'm Vidmon from Forby. Today I'm going to discuss a topic about activeness to fall. In this case, patient is conscious and coherent, GCS is 50. So you can understand that patient is in loss. And let's imagine a patient is admitted in Florida, say case of otitis media. And in this patient, lactose is added. So we all know that patient wanted to go to bathroom at several times. And before this incident happened, the primary needs already visit the patient and inform him we will have endorsement time and meet all his needs. And when the nurse left, patient how to feel to go to bathroom, and he himself feel that he's okay. So what he will do? Suddenly he pulled down the side rails and he's gone to bathroom. Suddenly he felt dizzy and he fell down. No injury happened, but this case is marked as an incident of fall. So we all know that what is the next step Vikaya done, and we want to inform the doctor and the nursing supervisor, doctors, and everyone is informed this case, and Vikaya, primary needs done the Vikaya. So let me check what are the contributing factors of this fall. First one, you know that yeah, okay. Could you please mention what? Yeah, okay. Could you please mention what is the contributing factors? First one, you know the okay.
Just give.
Yeah, first one you can say the patient in this medication there is lack of.
Mic.
For us in our department or other departments, especially in patient, our problem in sometimes the call bill. Not most of the time. The call bill will ring 1 minute, 2 minutes, 3 minutes, 4 minutes, 10 minutes, nobody answer. the patient wants to go to bathroom, he will remove the side rails, he will go like a hero, he will fall down. Most of the time, we will discuss this one, but when we will do investigation, we will tell the patient did not wait for the nurse. How much he will wait? 10 minutes, 15 minutes? Alas, he will do it on herself. So, the answering of call bill is very critical. The other thing, for the other patient, sometimes he need water. The thing around him, nothing there. So, he need water or need to eat. He's calling the nurse, she's not coming. He will go there and falling down. Right. This case, the most important, the call bill. This case, the call bill, during the endorsement, some staff, they are busy during the endorsement. So we need someone, at least healthcare assistant, to follow during this time. The other thing, don't be late more than 5 minutes for the call bill.
Thank you, Sir Hamad. Okay, thank you, Sir Hamad. So the contributing factors are patient is using the laxative lactose, so he wanted to go to bathroom. So we want to careful about this type of patients. We want to frequently observe this patient. And second one is patient diagnosis. Already I mentioned that is otitis media. So constant disease is there. And next one is secondary diagnosis, DM and hypertension. And fourth one is patient is not using the call bell. So what are the action we can do in this case? For sure, there is counseling to the staff nurses. But there is counseling to the she mentioned everything. Then also she get counseling. Okay, next next one is we can educate the nurse as well as the patient. In this case, patient is GCS 15, so we can educate the patient also. And in all the staff, in all ward there is HCA. So we can ask the HCA to look after the patient while the time of endorsement. And that time the HCA can take care of the patient. And all these simple steps we are following in our nursing care, we can avoid the huge falls in our departments. Thank you.
If the patient Bangladesh, how you will do it?
Bangladesh, we have staff, we have in this hospital different languages, different nationalities working. So it is easy, no problem.
என்ன சேஞ்ச் ஆகுது
Next to mom, okay, thank you.
Please, with you now. With you? A lot of change. I know. You do good.
Good morning. Good morning. Welcome to Kamsi J Newsline. Today, I would like to invite our guests, our gorgeous, active ladies of Kamsi J, from inpatient department, Ma'am CP. Please come. From our nursing quality, Miss Amira, please join us here. And from nursing educator, Miss Marwa.
Roy, light there. You can put light.
Today, we invited them to share with us the full assessment and full preventive measures. So it will be clear to us, and hopefully we will not have any confusion about it. And also, we will be able to link leadership skills and how to prevent falls in our institution. For my first question, I would like to ask from Nurse Educator Marwa, what is the importance of fall risk assessment and how we will make sure it's correct and valid?
Good morning, everyone. First of all, if you make it assessment at the right way, we can prevent any from happening. Then how do you ensure it's correctly? If you are making assessment as mentioned for the patient condition, and if you make it for every shift at right, and if you make assessment for patient, if you haven't changed any behavior, it should be accurate.
What are the problems why we are having inaccuracy in the assessment regarding Morse fall?
Okay, sometimes if you nurses make it an improper assessment for the gait and balance, and maybe not taking for history good, and not making for interview, and sometimes if you are not checking for medication sheet, and if you have any change condition, and we have unright the making assessment.
Thank you so much, ma'am. For my next question, it will be addressed to our nursing quality, Ma'am Amira. It's about policy. Do we have a clear policy about reducing patients' harm associated to fall?
Actually, fall, reducing the risk of patient harm resulting from fall, this is one of our 6 IPSG. So it's one of the standards of each hospital that we need to have a policy regarding this. So if you open all the shared folders for the policy and procedures, you can find it there. Under you can check it in the search field. Type reduce the risk of patient harm resulting from fall. Otherwise, you can go directly to quality shared folder. You can find it there under the APP or administrative policy and procedures. It's the last policy there. It's APP Gen 295, reduce the risk of patient harm resulting from fall. So we do have a clear policy, and we are, as a matter of fact, we are making it as the policy of the month this month of June.
Can you give us an overview of this policy, ma'am?
Okay. Actually, this policy has been a long policy, and I know everyone is aware of this. It says what a fall is. So just I want, as a handler of the incidences of fall, I would just want to say a fall, it's a downward, non-voluntarily placement of the body towards the ground. So what does it mean? For example, a patient that is reliable, GCS 15, oriented, and you saw that this patient is on the ground, but it's unwitnessed. But the patient says he did not fall. He sat on the floor, just like one of our case that was reported. This patient, we can consider he did not fall because he is on his right mind and he can say that he really did not fall. But for example, you saw a patient, she is GCS 7, and then he is on the floor and it's unwitnessed. Or for example, a psychiatric patient, and he is on the floor and it's unwitnessed, we can consider it as unwitnessed fall. So this is the reportable fall that we are saying. Also in this policy, we are talking about the assessment, which is a very important part of the nurses. So for the assessment, as an update, we recently changed the policy. We said that all the patients in ER, critical care, procedural areas, sedation areas, and all recovery room areas, they have to be high risk for fall. Otherwise, when they will be transferred back to the ward or in a lower acuity, they have to do fall reassessment. So assessment for fall, we do it within an hour of admission, every transfer, every time we will give high alert medications, and every time we will have sedation and a post-fall as well. So we need to have a reassessment for fall.
Can you explain more, ma'am, about the risk score and the prevention?
Alright, for the risk score, this is very important because each nurses, they know how to do the Morse fall assessment. But the question is, do they know what is the implications of the score? So we have the Morse fall assessment scale. This is composed of 6 criteria. We all know this, like history of fall. So there will be a yes or a no. There will be if the patient has a secondary diagnosis, like if he has 2 or more diagnoses, so you will just put there yes or no. If patient's mental ability, is he oriented or is he confused? Also, it's there the gait of the patient. Is the patient having a normal gait, an impaired gait, or a weak gait? Also, the use of mobility aids. So, is the patient normal, bed rest, or nurse assist? This is one category. Or if this patient is using crutches or walkers, or none at all. So there will be a score. If the patient's score is 24 down, it will be no risk. So no risk, as we have already talked about, no risk, you have to do the standard fall preventive measures, which all of the other speakers already talked about it. Now we will focus on the low risk and the high risk. So those having a score of 25 to 50, they are considered as low risk. Those having a score of 50 up, they will be 51 or higher, they will be considered as high risk. So what's the difference? If the low risk and high risk, you will put both the star fall signage and you will put it in the head part of the patient and also in the nurse's station. The only difference between the two, for the high risk for fall patients, they can consider putting the patient near the nurse's station or having a seater. But the rest, they have to do all the standard fall preventive measures.
And then how we will report fall if there's incidents in our unit?
In reporting fall, as I said, first the nurse, she has to know, is it a reportable fall or a not reportable fall? So if the patient says, I did not fall and he is reliable, he's oriented, this is not a reportable fall. But if it's a reportable, they have to inform their charge nurse, they have to inform the doctor, the attending physician, the nursing supervisor, and also the nursing quality, and lastly, they have to document and they have to do it in Vicaya.
Okay, thank you so much, ma'am. For my next question, it will be addressed to my three ladies. This question is, can you tell us about the barriers that we have seen in the implementation of fall measures? To begin with, from our inpatient department head nurse, Ma'am CP.
Good morning, everyone. So, as one of the head nurse, I observed 4 barriers that result to the fall of the patient. Number 1 is for those uncooperative patients. Uncooperative patients, for those, even though the nurses inform them, Baba, Mama, not to go out of your bed, but still, they are stubborn. They will really go out of their beds. As Sir Ahmad also mentioned, if they are calling you and you are taking time to come back to their rooms, of course, they will go out. But there is already instruction from the nurses. So we call that one the uncooperative patients. Number 2, wrongful assessment. So for example, you have 5 patients. One of them is low risk. Whereas you didn't see that there is crutches or cane in the corner of the door of the room of the patient. So you consider the patient as low risk, whereas the patient is high risk. So one barrier. Number 3, lack of time. Okay, you are busy for your documentation, but your patient is calling. So you lack time, you didn't manage your time, and the patient keep on calling, but you disregard, it will result to fall. And lack of effective strategies from the administration, from the head nurse, and other part of the healthcare. That's it.
Okay, also in my opinion, the language barrier is very important, and the patient a lot of the time refuse and the uncooperative with nurses. As 3B cases and the 2A, we have a lot of the a lot of the patient refusing and uncooperative with nurses. And also, some patients are confusing. We cannot really make assessment for this patient. Thank you.
Actually, after the RCAs, the numerous RCAs that we did, most of the things was mentioned already by Ma'am Marwa and Miss City. I just want to add regarding the endorsement time. So that's why we are actually encouraging the HCAs, they have to answer during endorsement time, and the primary nurses, they have to inform the patients about their needs prior to endorsement time. They have to inform that before that we will have at least like how many minutes of endorsement time. If you have anything, you can ask from now. Otherwise, our HCA will attend you in a while. And also the checking of the frequent checking of patients' needs, especially for high-risk patients.
How about the leadership and management? What are the strategies that head nurses and admins are doing in order to prevent fall? City?
For the head nurses and for the administration, we have the fall prevention random monitoring. I will show you this one. So it was created to monitor the fall incidents in all areas. So let me tell you some of the monitoring that we are doing. More fall assessment done. So from the head nurses, from the charge nurses, they have to check randomly. For example, if they have 30 patients on a daily basis, we have to select one, and it can be also in the evening. So we have to check if the Morse fall assessment is done. And number two, we have to check if there is a fall scar inside the bed of the patient to caution us that this patient is high risk for fall, and also in the board. And number three, we have to check if the call bell is within the reach of the patient. So we really have to provide the call bell within reach of the patient so that some of the patient will not go out of their bed. And we have also the fall audit to see if we are exceeding or beyond the benchmark. So we have the KPI fall prevention audit. And we have also providing from the administration, they are providing available resources. One is like, for example, providing sleeper for all the patients, mashallah. We have this one. And also, we have to apply a strategy in preventing all of this one. And also, educating the staff nurses to apply all the prevention measure for all the patients.
Okay, Ma'am City, thank you.
Yes, everyone is there. We have the PPI meeting with all the hospital. We are doing with the CEO and with the quality. And for it will go for root cause analysis. And after that, we'll say the system of problem and we come with the recommendation and approve it for the care. So it's measured available in the hospital.
Thank you, ma'am. How about you, ma'am? For my next question, like it will be the second to the last. I want you to give last message to all our staff in order for us to prevent fall from happening. Ma'am, okay, start.
Okay. If you know how did you make as assessment as accurate and critical thinking, it will be driven for any fall happening.
How about you, Ma'am City?
So my message to all the staff, make sure that your fall assessment is correct, okay? Because in your fall assessment, you will take this one for your treatment of choice for the patient. And number two, as nurses, we should have critical thinking, critical judgment if this patient is high risk for fall. So I should come frequent to check on my patient. And lastly, because the patients are being hospitalized for their illnesses, so of course, they are being hospitalized so they cannot do their daily living. So our role as a nurse is to provide a high quality of care for them so that you will have a high quality of service also for all the patients. Thank you.
Okay, everything we have already talked about the different things, preventive measures that we are supposed to do to prevent fall. So I will just make it very short. For my side, I think it's everyone's responsibility to prevent patient fall, trips, and patient fall. So if you have seen a risk or a hazard, do act. Do not just keep silent there. And to make it in the lighter side of life, I want to leave this quote. In life, everyone can just, in love and in life, everyone can just fall. But in our hospital, in CAMCJ, we say no to patient fall.
Thank you so much, our guest. I hope everything regarding fall assessment and fall prevention are clear to everyone. Thank you for watching our
So, in summary, the role of nursing, of nurses in fall prevention varies based on staffing concentration and management decisions. But generally, the nursing role in the prevention includes completing and documenting patient fall and assessment, documenting and patient-specific prevention practice, monitoring patients' conditions, reporting falls to the physician, obtaining medical orders from the physician as needed, supervising nursing aides, education the patient and family for fall prevention, obtaining the supplies like cane and walker, etc., near to the patient to prevent the fall. Nursing aides also play the part in the prevention of patient falls, including elevating the patient's environment, evaluating patient's environment for safety during the patient care practice, performing care plan tasks and reporting nurses when tasks are complete, reporting any changes in the patient's medical condition to a nurse. Following the nursing process, assessment, diagnosis, planning, implementation, and evaluation reduces the patient's risk of fall. Following all these steps ensures the patient complete fall risk assessment. And to use your judgment and ethically to adequately plan each patient's individual fall prevention plan, working with multidisciplinary team to ensure your patient's needs are met. Thank you everyone for attending. Anything else? Consider?
Good morning once again. So we would like to call all our resource speakers. So we would like to call Ma'am Royla and Ma'am Ines to give the certificates for all our resource speakers for sharing their valuable knowledge during the inpatient nursing grant rounds, Catch Me Before I Fall. So to begin with, let me call on Ma'am Rawan Saadi Al-Zamrani. Next is Miss Siti Ijara, yours truly. Miss Brenda Fernandez. Today is our graduation day. Miss Marwa Basha. Mrs. Maria Charmelot, Miss Yvonne Claire Bayoyos. Miss Vidomol Divas. Vidomol, head nurse will represent her staff.
She's on
Sir
duty.
Ahmad.
Wow.
Miss Ann Kaiman. Miss Sarah Marwan Al-Katabi. We have Mr. Paolo Rayo. So from the nursing education, would like to recognize all the inpatient departments for their active participation. Let us call on 4B male medical ward. From 3B female medical ward. We have from 4A medical surgical ward, 4A, Ma'am Fatma. From 2A isolation, first week. We have 2B female surgical ward, Ma'am Rawan. We have neurocardio ward, 3A.
One, two, three.
Thank you very much, Lee, for the very effort for providing this opportunity to promote the excellence of care and the interdisciplinary collaboration with this innovative approach. Thank you very much. Thank you.
We will proceed with a question and answer as we go to the different departments for our gifts and prizes. In the meantime, we would like to thank our guests for joining us in this insightful presentation. We would like to also thank the participants of this events, to our best actors and actresses of the inpatient wards, to our very cooperative head nurses, to our production designers, to nursing education and nursing quality, to our generous sponsor and very supportive nurse manager, Ms. Inas, and to our motivator and energetic, Ms. Loida, and most especially to Mr. Roy Cordero for making these things happen. Your work is going to fill a large part of your life, and the only way to be truly satisfied is great work, and the only way to do great work is to love what you do, by Steve Jobs. Thank you.
Alas. Finish.